And I'm going to start. Good afternoon, everyone. Thank you for joining us. This is Stephanie Winters from the Vermont Medical Society. We're just going to give people a few seconds to be able to log in, and then we'll get started shortly. Good afternoon, everyone. This is Stephanie from the Vermont Medical Society, welcoming everyone to our Thursday webinar series on refugee health. Today, I'm pleased to welcome our speaker, Dr. Heather Link, to talk to us about caring for new American children and screening and treatment of tuberculosis infections in arriving children. I just have a few disclosure slides to go through, and then I will kick it right over to Dr. Link. So this webinar series is approved for CME. It's 0.75 hours. It's also approved for social work credit through UVM. And Bertie Polly, our VMS office event and program assistant, will be sending out information on how to claim CME. It is due within 30 days of the event, so make sure you claim it within that time period. This is just a slide letting you know that we don't have any disclosures, no financial disclosures, and our presenter has no financial disclosures either. The VMS has a webpage. It's vtmd.org/refugee health. And on there, it's the remaining list of our webinars that are happening through November, and also all the recorded sessions with presentations, and then a number of resources that Dr. Andrea Green has really put together and pulled together for everyone. And with that, I'm happy to welcome Dr. Link. Dr. Link is a pediatrician at primary care at the University of Vermont Medical Center and works closely in managing the care of refugee and immigrant patients at the New American Clinic. So thank you for being with us today, Dr. Link, and I will kick it right over to you.
Thanks, Stephanie. I'll go ahead and share my screen. Get things underway. All right. Okay, so we'll touch today on caring for new American children, the screening and some treatment options for TB infections in arriving children. This is something that I've been doing here in Vermont since I moved here about 9 years ago. And I work closely with Dr. Green, Dr. Weinberger, and Dr. Saya. We're part of the pediatric New American Clinic at Pediatric Primary Care Burlington with the University of Vermont Children's Hospital. It's a whole lot of names. We take care of all newly arriving children, and we are honored and thrilled to be able to provide that care to arriving families. I'll briefly go through 2 short pediatric cases that have come my way in the last few years. Treating tuberculosis infections is always a bit of a challenge, and it can often be a challenge for reasons that you were not anticipating. So this first case details a young woman who arrived from the Democratic Republic of Congo. She arrived in the month of June. Her pre-departure paperwork noted that she had had a positive IGRA test and a negative chest x-ray prior to departure. When she arrived, she was asymptomatic, didn't have any fever, she wasn't coughing, she hadn't had weight loss, she felt absolutely fine. She couldn't remember having been exposed to tuberculosis, but really I haven't ever had anybody tell me that they could. And we did try to repeat the IGRA stateside, and we also tried to repeat a chest x-ray. We spent 3 months trying to do that. And we can go through some of the reasons why when we explore some of the pitfalls of treating tuberculosis infection later. And we also noted that transportation was very limited for this family. The second case that I have was actually quite some time ago. It was one of the first TB cases that I treated here at my time at University of Vermont. This was a little 4-year-old from Nepal. She had a positive IGRA on arrival and a negative chest x-ray, and she felt just fine. At that time, the recommended course of treatment was daily isoniazid therapy. She began having fevers near daily. So we'll talk a little bit about the pitfalls of this treatment and how we got through that. All right, tuberculosis disease, a quick review. We just got this video working. We're gonna give it a minute to try again. It's a minute and 41 seconds.
Also known as TB, is spread through the air from one person to another. When someone with pulmonary TB disease coughs, TB bacteria are expelled into the air in tiny water droplets. These droplets can remain floating in the air for several hours, making it possible for someone nearby to inhale them. Once a person has breathed in droplets that contain TB bacteria, they travel down the trachea and enter the lungs, where they collect in the alveolar sacs. Once in the alveolar sacs, the bacteria begin to multiply. The body's immune system starts working and macrophages begin to surround the bacteria. A granuloma is formed to keep the bacteria from spreading. The TB bacteria remain in the lungs, but the body is protected from disease by the granuloma. In 8 to 10 weeks, the person will most likely test positive for latent TB infection. The progression from latent TB infection to TB disease occurs when the granuloma break open and the TB bacteria multiply. Then the person becomes sick with TB disease and may be infectious. This progression can occur immediately after infection, many years later, or not at all. When the TB escapes from the granuloma and begins destroying a person's lungs, it's called pulmonary TB. TB bacteria can also enter the bloodstream and travel to other parts of the body, causing extrapulmonary TB.
Okay. So one thing I like about that reminder is it's short and sweet, and it clearly differentiates between a latent tuberculosis infection and an active tuberculosis infection, which is something that when treating children, we're keyed in on. And as the video reminds us, this could take years, but it could also simply be a matter of weeks or months. And we certainly have active TB in many of our arriving children. Far more common is a latent tuberculosis infection. And I like the reminder that simply because you're exposed to tuberculosis doesn't necessarily mean that you automatically have active tuberculosis disease. So it behaves a little more differently than other respiratory illnesses that we're familiar with. Today, we're going to focus on latent tuberculosis infection, but I'd like to give you a little bit of an overview about tuberculosis and the scope of illness in the world, in the US, and in our corner of the world. And what's important to note is that there are entire divisions at the Centers for Disease Control and the World Health Organization devoted to tuberculosis. This is a massive topic. So we are really, truly scratching the surface today. World Health Organization in their tuberculosis report from 2021 estimated that over 10 million people are sick with active tuberculosis every year. There are over 1.5 million deaths each year from tuberculosis alone, and that potentially a quarter of the world's population is infected with tuberculosis. I find that third statistic to actually be probably the most telling. And that reminds us that we can get very narrow-sighted in Vermont and indeed in the US, suspecting that this is actually not a very prevalent disease, when in fact, most of the world's population resides quite far from us and in all other aspects of the world. And this is a worldwide disease. Tuberculosis in the US. So there's just a few that are highlighted here where the incidence is a little bit higher. And little Vermont is not highlighted, but big New York next to us is. And that's important to note because we live in a global society. People go back and forth all the time. I have many families that have extended family in the New York area, and they frequently move back and forth between various counties. 2020 reporting was a little bit of a puzzler, and we all know why. So these the case numbers are going to look possibly a little wonky, and they can either be lower or higher. So it will be interesting to see if 2021 and then 2022 comes out. But in 2020, there were over 7,000 active tuberculosis cases in the US. That's quite a bit when you think about the distribution of the US population. An estimate of almost 13 million with latent tuberculosis infections. So this is all TB now, including adults. And then there was a dramatic decline in 2020. And I think we all know the reason why. TB incidence in non-US born individuals. I used this map to remind residents when I gave them this talk that we are in a very fluid society. So while we look at the map and Little Vermont is just kind of in a pale blue, if we look at Maine, it's in a darker blue. And we have a substantial non-US born population living in Maine, and a lot of in-migration between both Vermont and the state of Maine. So keeping in mind that families are fluid and are often relocating to where their extended family members are for better supports. And we have a lot of back and forth motion between many of the states. Pediatric TB. Okay. Pediatric TB is defined as anybody under 15. So that does take out a reasonable portion of the people that pediatricians actually care for, right? So I still care for kids that have latent tuberculosis infections and are in fact over the age of 15. However, the CDC defines pediatric TB as under the age of 15. In 2020, there were 317 active TB cases. And then you can see in the pie chart where the biggest distributions of those are. So in the 10 to 14 years, and then also in the 1 to 4. I sort of puzzled over the reasons why this could be. Actually, it's fairly evenly distributed if you kind of look at it really a little bit more closely. I wondered about that 1 to 4 age range, and I wonder if it's just simply because of the proximity to other adults in their family at that time, where they're really not out in school, but they're really quite home, and usually in actual physical close proximity. And then again, most of the cases were in less than 5 or in over 10. So we're certainly seeing this in the schools, and school nurses are an important part of this care. So taking a world view, while here in Vermont, I circled a few of the places where we're having the most immigration from currently, and then one of the more recent ones. So Afghanistan, Democratic Republic of Congo, and then the little circle over there over Little Nepal. Small but mighty. Afghanistan reported through the World Health. Oh, my computer just asked me if I'm playing music, and the answer is no, I am not. Afghanistan reported 75,000 cases in 2020, with a full quarter of those cases represented in kids ages 0 to 14. And we know that the airlift of 2021 found many families relocating to our little corner here of Vermont, and we are certainly taking care of infections now. Democratic Republic of Congo, where we've probably had more of our recent streams of migration, reported close to 300,000 cases of active TB, with a full 11% in children ages 0 to 14. So we are definitely seeing these kiddos arriving here in Vermont. I'm going to close this if I can. No, I can't find my cursor. All right, testing for tuberculosis. So what you can see here pictured is something that lots of us have spent time on, trying to measure and quantify our TSTs, or tuberculosis skin tests. There are a few ways to test for TB. When a family arrives, when kids arrive here in the US, we take a look at their pre-departure paperwork, and sometimes we can work off of that, and most oftenly we will repeat it, given that there's often a 3-month period between their departure paperwork being worked on and then actually arrival in the US. And during that time, they may become infected with TB. So the first one that I'm talking about is actually not pictured here, because it's the IGRA, or otherwise known as the quantiferon. This is a blood test. And this is really considered the gold standard for testing for tuberculosis infection. The strength of it comes in, you can get the results pretty quickly, typically within a day at the University of Vermont. There are no false positives due to vaccination with BCG vaccine, which is given internationally to protect against tuberculosis. The drawback is it's expensive. The plus side is here in Vermont, it is covered by Medicaid, and all newly arriving refugee families are covered through the Medicaid program. So it is no cost to them, which allows us to more broadly use this. This test can be used down to the age of 2, which is great. It really expands our ability to test, but it does have a few limitations. And one of the things is kids arrive who are in fact less than age 2. And so in those kiddos, we need to use the standard skin test or the TST. And I think that I've placed TB tests, the RNs in my office have placed them, the LPNs have placed them, and we all do them just a little bit differently. And then of course, the reading of these has to occur 48 to 72 hours later, which if both transportation and language is a barrier to care, can be very difficult to overcome. It often means arriving on a weekend during which the clinic might run very differently in my office than it does during the week. So there can be confusion as to why a patient is there. And then the reading is quite subject to interpretation. So as you can see in the picture here, this is the correct interpretation. So the little measuring stick there, the little ruler, perpendicular to the arm, and you're measuring induration, not redness. So many patients have had false positives reported if the redness was reported as the actual induration instead of just that induration. So really trying to find the edge of the lesion, which is formed at the injection site. It can be challenging if it's small or if your fingers are cold. It can be challenging if you don't have the right pen to try and draw a line over it. It has a lot of challenges to it. Briefly, interpretation of the TST, it does require interpretation because IGRAs come back either positive or negative. So there's not much else to be done about an IGRA. It's either positive or negative, and you can move on to your treatment choices. TST usually requires, when I'm looking at a TST and I have to interpret it, I have to usually get out a book or look it up and go back all through my parameters. So briefly, the general idea here is that if it's very small, it's only positive if you have more risk factors. So when I'm teaching to the residents, I'm generally and broadly teaching them that, say on a board test, you are looking at small induration, only positive if, say, for example, you have some of the most important risk factors to be aware of that would set your immune system up for a problem, and that would be active HIV infection and also contact with a known contagious individual. And then as we go up in increments of 5, some of those drop out a little bit and you get a little bit broader expansion of who actually qualifies as positive. So at greater than 5 or equal to 5, individuals with HIV with a close contact or an abnormal prior X-ray, greater than 10, having an underlying medical condition like diabetes, asthma does not qualify, children under 4, foreign-born with has elevated incidence, and that's recent, or also in the past, and also working in a high-risk setting, so something like with the incarcerated population. And then the very largest of the induration is anybody else ever who's over 4. So it captures quite a few people. Treatment of LTBI. So once you have your positive IGRA, or once you've determined that your TST is positive, you of course would proceed with a chest X-ray. So moving into our category of latent tuberculosis infection, otherwise known as LTBI, would suggest that you've already obtained a chest X-ray and it is negative for any markings that would suggest active tuberculosis, which is a very different clinical pathway. So in the time that I've spent here in Vermont, the recommended treatment course for latent tuberculosis infection, so that is somebody with a positive IGRA or a positive TST, negative chest X-ray, and clearly no symptoms, we can proceed with treatment to eradicate the tuberculosis infection so they do not develop active tuberculosis in the future. It used to be daily isoniazid, which we can talk about some of the pitfalls when we return to the cases that I mentioned earlier. Currently, it's 3 months of once weekly isoniazid and rifapentine. There are some side effects to these medications, and the next slide will cover that. I can tell you that so far in my experience over the last several years, this is a very well tolerated medication regimen. It can be given and typically is administered at school by the school nurse. So we have the families bring in the medications, or we do it for them if they're at one of our school-based health centers. The nurses administer them once a week and also check on symptomatology and be sure they're tolerating their medication. And then we see the patients once a month through that time to be sure they're not having an activation of the tuberculosis or a serious side effect of the medication during that time. There are alternatives to this medication. I have not had to switch out of this particular regimen since beginning to use it several years ago. So it's been very well tolerated. Okay, so monitoring this particular regimen, isoniazid and rifapentine both pose some difficulties while you're taking them. Although I will tell you, I haven't had anybody have a problem yet, but they certainly do. This absolutely does occur among patients that are taking this regimen. Isoniazid can cause an increase in liver function tests, can cause fulminant hepatitis, can cause peripheral neuropathy. Most commonly, people complain of numbness in their toes or feet, and also GI complaints. Rifapentine can also be, quite frankly, hepatotoxic. It can cause an itching and hypersensitivity reaction, which can be a little difficult to sort out in a new kiddo who's experiencing very dry winters in Vermont. GI complaints, and also the big one is orange pea. So we try to counsel ahead of time when kiddos are starting this medication that your pee is going to look orange, and it's really kind of interesting and fun not to be worried about. We don't routinely monitor with pre-treatment or during treatment LFTs. We watch clinically. Okay, so we know that if we're following the treatment of isoniazid and rifapentine for 3 months and they're taking that medication weekly, typically at school, under the supervision of a school nurse and with the supervision of a physician once a month, that when we get to the end of 3 months, we can have a little celebration and complete their treatment. They're given this little blue card, which is promptly lost, but we encourage them to keep a copy of it. We make a copy of it and load it into the electronic medical record at the University of Vermont, so it is there, essentially indicating that this patient had a positive test for TB, they underwent the appropriate treatment that was supervised, and they've completed it. And this allows them to have their memory jogged, because kids go through treatment with this, say at the age of 11, and then when they take over their own healthcare in their 20s, it can be kind of hard to remember exactly what happened when they were 11, what medications they took, and if they had any trouble with it. It also encourages, and it says, stands as a reminder to not retest. So once you've been through treatment, you don't need testing again. You simply need to let your healthcare provider know, I've been treated for a tuberculosis infection, it was not active, I completed it, and I've been symptom-free. We encourage families to monitor and to encourage their kids to watch for symptoms. And it's something that I let the parents know to really engage with their young adults with as they become young adults, to let them know that as they take over individual care of their own health, that they know to monitor for symptoms, because you can occasionally get a reactivation. The goal, of course, of therapy is eradication. World TB is March 24th. I was scheduled to give this talk initially in March, then sadly developed COVID, so I didn't, and we gave it in June. But think about this as you come through the winter and hopefully have weathered all of the winter viruses. Consider refreshing your knowledge about tuberculosis as you come out of the winter, and just be thinking about it, especially in newly arrived families or families that may have transferred into your practice, but that have immigrated from other countries. Okay, back to patient one. So patient one was a 12-year-old from the Democratic Republic of Congo who arrived in the month of June. She had a positive IGRA prior to departure and a negative chest x-ray. We struggled to repeat the IGRA stateside. It had been over 3 months. And due to scheduling issues and collection issues, we were never able to do so. We struggled to also get a chest x-ray because it required coming back to the medical center, which was difficult for this patient, given the family structure and lack of transportation. After discussion with infectious disease, we decided to work off of the pre-departure paperwork because we needed to move ahead. She had been asymptomatic. She completed a 3-month course of isoniazid and rifampicin. She took care of that at school. She had 0 side effects, which was wonderful. I got to see her through her treatment. She would pop into the nurse's office and take her medication and zip right back out to class, no problem. She completed her treatment and she's feeling absolutely fine right now. Patient number 2, I saw several years ago. This was the 4-year-old. She had a positive IGRA. I was happy to have been able to have done an IGRA at that point. The rules had just changed at her time of immigration, which moved the ability to do a serum quantiferon or IGRA test from down to age 5 down to age 2. So again, the lower age limit is 2 now. And I was grateful for that because TSTs, again, I find just to be challenging to administer and to read. And this young patient began a daily course of isoniazid, and taking any medication every day is a challenge for most people. It can be a challenge to take a medication for an infection that you don't see or feel. And it can be a challenge to get a crushed tablet down a 4-month-old or a 4-year-old every single day that doesn't really taste very good. She developed daily fevers. And so we had to begin seeing her with more frequency, wondering if first, maybe it was a viral URI, or could this potentially be an activation of her tuberculosis? We repeated a chest x-ray and it was not a reactivation of her tuberculosis. So it seemed in fact to be a side effect of the isoniazid. Other regimens didn't really seem to be like a good plan for her at that time. So what we were able to do was to have coordination with the Vermont Department of Health and working with a public health nurse who was able to go out to the patient's household daily and monitor for fevers and to really see if she was in fact having fevers. We were able to get through. She was very, very, very mildly having fevers. And she did complete her 9-month course of it. It wasn't easy. And doing a 3-month course now, I think would have been substantially easier for this young patient. Okay. So I have a few resources here. World Health Organization is very knowledgeable and there's so much information available at their website, all about tuberculosis, its treatment, its testing, its prevalence, its incidence. It's really staggering, as well as the CDC has excellent resources and training for providers taking care of patients with tuberculosis. I'll stop my screen share for now.
Great. Thank you so much, Dr. Link. That was a fabulous presentation. I am not seeing any questions in the chat, but if people have them, please enter them in. I was wondering, and I apologize if you address this, but so you are screening the kiddos. Do you do a broader screening of the family, of their family unit, whoever they live with? How do you handle that kind of screening?
Yeah, so the way it works for us as pediatricians is the family is screened with the infectious disease group at the hospital. So they do their arrival blood work and screening through infectious disease, and then are transitioned typically to the community health centers of Burlington. We do all of that for the kids in our office. So it would be really easy and nice to start taking care of the adults too, but since we're pediatricians, we're not able to do that. But we are able to help them to connect with area providers and specifically the community health centers of Burlington if needed. But typically all of their blood work and screening process has already been taken care of through the University of Vermont Medical Center.
Great. And so I'm assuming there's a good coordination between the two. If one is positive, then you make sure that the kid or vice versa is screened and appropriately
For the
monitored.
most part, sometimes communication can be a challenge. There's a wonderful new healthcare coordinator and liaison with USCRI, formerly known as Vermont Refugee Resettlement. And she's been tremendous in our community with helping us to know what's going on at the hospital and what we need to be aware of with our arriving families. Excuse me. So in other communities, there may be other individuals in that role of liaison for refugee health, which is helpful to lean on and outstanding for coordination of care.
That's great. Are there other, just one more question, are there other things that offices should sort of be aware of that you haven't addressed if they're trying to start seeing more refugee populations or more new Americans and they haven't before in regards to testing for tuberculosis?
Yeah, so for other organizations that maybe aren't seeing kids at arrival and so haven't had access to their early arriving information and have had a chance to really be with the families and the kids for a year after their arrival, and maybe a child's transferred or moved within the state of Vermont or moved out of the state of Vermont, and hopefully records follow, but receiving a large electronic medical record printout can be daunting and difficult to read. And so I think it's important to be asking about tuberculosis, even in a kiddo that maybe has been in the US for some time, and to be keeping that on your radar screen as part of the history and part of the physical. And typically the answer to the question would be, yes, I was treated. They may not be clear as to whether this was a latent tuberculosis infection or an active tuberculosis infection. So when I've been in that scenario, I simply try to parse out, was this one thing you took once a day? Was it multiple things? Maybe it was 3 months. Did you have a cough? Did you have to cough up some sputum? So I try to give some other clinical cues that might illuminate the difference between a latent tuberculosis infection and an active, because it can be confusing if kids feel fine. And I've had kids with active TB that feel perfectly fine.
Great. Thank you so much. Those were really helpful answers, and I think people will be really interested in that. And if you're watching on the recording and you have questions, certainly you can reach out to me and I can send them on to Dr. Link. So thank you so much for speaking today and giving a great presentation. And thank you to everyone for joining us. So thank you, everyone. Goodbye.
Yeah, bye. Thanks.